Welcome to Advanced Nurses. We connect with nurses who inspire other nurses by sharing their experiences. And so we're able to bring that information to you. Hello. Welcome to Advanced Nurses with ACD4N. And I actually have the coding nurse with me. And so today we are going to talk about a few things, but one of the things I really wanted us to dive deep in is to transitions. This year for me, my services have really shifted towards helping nurses with transitions. So I really want to help nurses kind of explore more about the different options they have as nurses and really kind of options or resources rather that they can explore to really help them, challenge their um, I guess challenge their boundaries and also for them to really look at what's out there for them if they want to transition into other areas of healthcare. So the coding nurse, would you just begin by just kind of introducing your services and like what you've been doing now as far as your services, any updates to your services?
My name is Jesse, aka the Coding Nurse. I had my company now for going to be 4 years next month. I started out just trying to share my experience as a nurse who wanted to get away from the bedside and how I got away from the bedside. I got away from the bedside via medical coding. And I started off with and to this day that's still my offering. I mainly provide nurses an accelerated course, what course says, an ICD-10 CM coding and ICD-10 PCS coding. And I had actually stopped doing CDI training because I had collaborated with AHIMA and I had signed an NDA where I had to not teach CDI for a year. So that is up. So now I'm thinking about getting back into training nurses for CDI and I just really wanted to help nurses navigate and really explain to them what moving away from the bedside means in terms of medical coding. And I have a lot of nurses, who contact me via my website, and they say, "Well, I want to learn medical coding so I can work from home. Well, I want to be a medical coder so I can work from home." And I explained to them that you don't want to be a medical coder because a medical coder makes between $20 to $25 an hour. I don't know any nurse, RN or LPN, that's really going to work for that and really be okay with that. So what I explained to them is you want to learn medical coding to combine that with your nursing education and your nursing credentials to allow you to work from home at the same rate of pay or sometimes more than what you are making currently at the bedside.
For me, like you mentioned before, the pay. So coming from a case management space, I already had my eyes kind of all over what everybody is doing. And so that's one of the beauties or one of the advantages you have of working in case management. You get to kind of see every little moving part. And sometimes, unfortunately, you get thrown into things. So sometimes people force you to have to do certain things and you're like, oh, okay, what is this? And like many things in nursing, if you don't really have a specific title or name for what exactly you're doing, then you don't even know if it's like transferable skills or not. So therefore, you may look at it as a favor, maybe even look at it as something that's just another task or just another checkbox or just another part of your duties. But really, when we start thinking about how things fit, I'm not saying you may not still have tasks and little things that you are asked to do in your role that you don't quite understand, but it's a very different experience when you can put things into context. So, like, yes, I'll give you a good example. In case management, oftentimes you may get caught up in things like keeping immunization, keeping immunization records up to date for patients or for members of like a health plan, for example. And so trying to coordinate getting into a patient's house to administer the vaccination or whatever the case is, or to confirm if a vaccination was administered on time, it may seem like, oh God, just one more thing to do. But if you think about the big picture, let's say from a quality perspective, when it's missed and you're looking at across a population, then you see it's the greater impact that it's actually having. It's not just one patient. It's really about having practices and operations in place to ensure that these are the kind of things that we're not missing. Because missing it on 1 or 2 or 3 or 4 or 5 patients, that adds up. You may have a whole health plan where they're saying that they're doing managed care, and half of the patients don't even have the annual recommended vaccinations. And so being trained in areas such as medical coding, for example, even though that's a whole career for some folks, and some people, this is what they do like every single day. As a nurse, it really is skills that enhances what you do, and it helps you to have a better perspective on quality and the cost of care. So, I really wanted to also get into gatekeeping. Have you, and you've shared this with me in the past, but are you still seeing gatekeeping practices within nursing? So I'll just preface this way. Although health information management is its own area, when it comes on to nurses who want to transition into health information management, whether it's via CDI or they go into some roles within, I don't even want to box it into CDI, because as I've learned over the past few years, it can come in various titles. So it ain't just CDI. It's turning
Right.
it. I've learned that it's a big old mishmash of a bunch of different titles. But the transition into HIM, I find there to be some gatekeeping there. It's a lot of mixed messages, if you ask me, because you have people in the space who don't have certifications, don't have any really specialized training. They're just entering, nurses specifically, into HIM through CDI, for example, and they're doing it, just off of there being a position open. There was just an opportunity. It was brought to their attention. They apply for the opportunity. They get the training on the job. And then if they want to go ahead and acquire a medical coding certification, they now can do it because they have the experience under belt. They understand what they're looking at. They understand the context of any kind of exam questions. And so they're ready to go. Are you seeing still over the years that you've been working that those practices are still going on as far as the gatekeeping?
Absolutely. And one of the most obvious examples of that is for me as an LPN. I've had several recruiters. Matter of fact, I had one just last week, about maybe a week or two ago, contacted me via LinkedIn, and and it happens all the time. They see CDI in my title and in my Instagram, in my LinkedIn bio, and they maybe look at my resume, but they don't look at my credentials. And then once I make contact and say that I'm interested, then I get ghosted. And I know why it happens, because I'm not an RN. So that in and of itself can be a potential roadblock, and it has nothing to do with ability. And that is one of the reasons why I work so hard with my company, the Code Nurse, and that's why I work even twice as hard, or maybe even harder, with my company, because I want to show, especially LPNs, that you don't have to be an RN to be successful. And God knows I have been successful as an LPN with no degree, and just experience and the right certifications and a lot of determination and grit. And I think that to your point, where you said, like, some of these people fall into these positions, and then as they fall into it, they begin to decide who can come in and who can't. And that is going to be across all industries. But I think that in nursing in particular, if you were trying to get away, because it's harder to get away from the bedside due to gatekeeping, because there's no such thing as a shortage. in healthcare, in direct care, you need to have X number of people to take care of X number of patients. It's just a matter of basic math. So they can't afford to restrict but so many people just out of just compliance and a whole lot of other things. But when it comes to positions away from the bedside, there is a little more control that someone can have over who comes in and what positions they have when they do come in. So I do experience it, and I definitely don't let it deter me. I don't let it make me any way but more determined to be successful.
Well said. I think for me, what I have noticed a lot of times with gatekeeping, and now this is as an RN, right, is that if you have I've heard it be called tribalism, for example, where you have a lot of the same people working in a particular space. So let's say I was recently looking at a survey poll, and the poll said essentially 74% of CDI professionals are RNs. And so when you see something like that, where you see 74% RNs, it makes you think to yourself, okay, so when you have such a large group represented in a particular profession, we're not talking about nursing. So if 74% of RNs of the nursing profession altogether is made up of RNs, I guess it wouldn't be so alarming, because you'd say, okay, well, they're all nurses. But when you're talking about CDI is very different. CDI is not nursing, right? So it's like when you see 74% there, some of those ideas or theories that come out of tribalism, for example, would probably suggest that there could be some issues around inclusivity when you have the numbers looking like that, because then of the 26% that's not RNs, how are those individuals treated? Are they allowed to gain opportunities to climb the ranks, for example? Are they given fair opportunities for promotion? And also, if they are looking to join certain projects or certain committees, do they have equal access? Right? Because that's what happens sometimes when you have a dominant group of people in a particular process, program, project. It's just the likelihood for there to have the others or the otherness, element in there, and having people feel isolated or feel like they don't belong is likely to happen there. So, and is that true, or am I looking at that incorrectly?
Well, you're not looking at it incorrectly, but what they have the same courses in terms of like anatomy and physiology, pharmacology, but I think that there's still a lot to be said for actual hands-on experience that a nurse can bring. I'm not saying that and the reason why CDI in particular is such a unique space is because nobody is innately prepared for it. Nobody, because it requires too many avenues, too many areas of knowledge. For instance, if you are a nurse, you may have been in a CCU, you may have been in an ICU, you may know how to do cardiac massage, you may know how to do IV push, you may know how to do hang TPA, you may know all of those things. You may know the etiology of every disease, but do you know how to sequence that admission to maximize the DRG? No, you do not. You have to be taught that. If you come from an HIM perspective, you may have had pharmacology, you may have had anatomy and physiology, but do you know that when you're reading that medical record, that bilateral plus 3 pedal edema could be a sign and symptom of heart failure? Right out the gate, no, you wouldn't. All that comes with experience, and all that comes with education. So that's why CDI, in particular, the gatekeeping for me is annoying, because, and also to that point, I currently have a job as doing inpatient CDI. My job title, my job offer is RN Clinical Documentation Specialist. I don't use it because it's illegal for me to use RN because I'm not an RN. I had to change it to just clinical documentation specialist. But my job title and my offer letter says RN clinical documentation specialist.
And that proves the very point around the gatekeeping. So, I mean, just imagine an industry where you have that kind of, I guess you would want to say, kind of the gray areas around the standard for entry, the standard to, to practice. And then in your case, I mean, I'm sure I don't know, have you ever worked with an RN with your credentials before?
No.
So that's, again, and this is the kind of thing where I feel like it brings me back to, again, where I was saying as far as nurses who are interested in like transitioning to different areas of healthcare, especially when we're talking about non-traditional roles and roles where you typically can work from home. So it really requires nurses understanding what it is that the kind of skills that you would really need to have that would allow you to add value, even if you were not holding a patient's hand. And so in CDI, there's so much that you can do. In CDI, there's many different CDI roles. You can be a CDI analyst, an educator, a CDI auditor, CDI specialist, all roles kind of stemming from, of course, clinical documentation and understanding what that medical record should actually look like. And then, of course, being connected to the right resources so you know what best practices, really is about. But again, all of this is really things that you would learn, right? So the RN has to learn about this new paradigm and learn about this new way of thinking about the medical record and learn about a new way and new things that you're going to be communicating with the provider. And not just RN, of course, nurse, because as we can see with the coding nurse, this has nothing to do with RN or LPN. And so many things that we do in nursing, I feel kind of goes in that way where I have many questions, especially around the new thing. And I've been saying this to Jesse for a while around nursing is STEM, because when it comes down to it, there's so many dynamic things that nurses can do with just the right bit of information. But I believe gatekeeping is really what holds people back. There's so much opportunity for you to learn, new skills, especially if your goal is to do something other than bedside nursing.
We want to hear from you. Schedule a free consultation or send us an email at advancednurses@acd4n.com or visit our websites www.advancednurses.info or www.acd4n.com.